Hello everyone, I'm Kayla Coleman, Marketing Manager for OraSure Technologies, and I am joined by Pam Pitts, our Director of Sales for Public Health. A couple weeks ago, Pam and I hosted a webinar called Innovative Strategies for HIV Screening During COVID-19. During and after the webinar, we received many questions around this topic. To that end, we'll be discussing those questions today. COVID-19 has presented many unique challenges among our communities and to our testing programs. So you may have some of the same questions as others in your line of work. For this session, I will be reading the questions that were submitted to us, and Pam will provide answers. If you have any questions about anything we discussed today, or if you have a question that we did not cover, we will provide contact information at the end of this video, as well as in the description box below. We've also included timestamps below if there are specific topics you would like to jump to. With that, let's get started. Pam, our first question focuses on the technicalities of our devices. The first question submitted was, what is the window period for using oral fluid compared to finger prick blood sample?
That's a great question, and really, to me, the question is about the window period in general. So an HIV test that detects both IgG and IgM can detect HIV antibodies as early as 20 days. However, as we've all heard on the news recently, it can take an individual longer to develop antibodies. So per the CDC recommendations, if someone feels like they've been exposed, they may need another test 30 days later. We really see no differences between the oral fluid and the finger prick as far as days to detection.
The next question is, what is the sensitivity and specificity of the oral fluid test compared to the finger prick blood sample?
It's a good question. So the OraQuick HIV 1-2 test has a sensitivity of 99.3 and the specificity of 99.8. The OraQuick In-Home test, which is the exact same device, the specificity and the sensitivity were impacted due to the FDA requirements that we do our study on untrained users. So the package insert for the in-home test states that 91.7 of HIV positive people test reported correct test results, and 99.9 of people correctly reported a negative test result.
Pam, you covered this a little bit in the first question you answered, but just in case someone missed it, what is the window period?
That's a good question. Again, I mean, even if we have to answer it a couple of times, the OraQuick device is equivalent to a third-generation lab-based test and can detect antibodies in 20 to 25 days post-infection.
How can viral load be determined?
Yeah, viral load is a medical test that is actually performed through a blood draw. And a viral load test, HIV RNA, and really measures the number of copies of RNA in your blood. The OraQuick HIV test does not test for viral load.
Another question we received was, what generation is this test?
Good question. So the CDC has really been trying to move away from using the term generations to define a test and really look more towards what does the test detect. Our test, the OraQuick HIV test, detects both IgM and IgG antibodies, which means we can pick up antibodies to HIV earlier than just a test that might detect only one antibody.
The next question is around batch testing. Someone had asked, is there explicit codes to distinguish one test from another while doing batch testing?
That's a good question. I mean, the biggest concern is that you would get someone's test mixed up. And so we recommend that this can simply be solved by just taking a Sharpie or whatever you might have and putting a person's unique identifier, whether it's their birthday or their mother's birthday or whatever, on their specific device.
Okay. For patients who are taking PrEP, what is the expected false positive rate?
Yeah, so the false positive rate or the specificity of the OraQuick HIV Advanced test, which is the same as the in-home test, is 99.8, meaning you can expect that 2 people per 1,000 tests done has the possibility of being a false positive.
Okay. Are there plans to create an instructional handout or a self-swab procedure for clients to read before self-swabbing, for instance, in a batch drive-up testing scenario?
Yeah, we heard this a lot. We are working right now to work out some patient flow pieces and further guidance to help provide back to programs who are implementing these innovative programs.
Do you know if there are more false negatives or false positives if a client has or has had COVID-19?
Yeah, so in order to know if there are more false negatives or false positives on the OraQuick HIV test due to someone having had COVID or not, we would need to be running what's called cross-reactivity studies. At this point in time, we have done no cross-reactivity studies for COVID-19.
We also received a good amount of questions around the self-test specifically, so the OraQuick In-Home HIV Test and the programs we discussed during the webinar. So the next few questions are going to focus on those topics. So the first one for this topic was, does the in-home HIV test detect IgG, IgM, or both?
The in-home product tests for both IgG and IgM.
Do you have any other languages?
So we believe the question is the test kit offered with instructions other than in English? And the answer is it's available in English and in Spanish.
The next question we had submitted was, safe at-home testing is an amazing option for organizations like the one I work at right now. Can you elaborate on the difference between public health departments preferring blood setting versus oral samples?
Yeah. So many organizations don't have a preference over fingerstick or oral fluid, and we know that the patients prefer oral fluid sampling. The accuracy between oral fluid and blood is very similar. For some patients, the use of blood may be what they're used to, and so it could be that that has been one of the challenges a state department has had to face.
How can you guarantee that results are reported back to you from clients if they're using the in-home or HIV self-test?
Yeah, this is really kind of speaks to the heart of in-home testing and public health. There's really no guarantee that someone will report back. What programs who have, overcome this barrier have done would be to include information with the test kit that says, if you test positive, call this number. Post-testing surveys that drive people to websites, text messaging follow-up. Programs that have been successful have reported that about 40% of folks who test positive with the test kit do contact them for follow-up. The other way, of course, and we discussed this on the webinar, is to be able to use your client level data to cross-reference your HIV surveillance data to see if that person did eventually link into care.
The next question focuses on the coupon code programs we discussed during the webinar. So the question is, can you specifically state what other information the coupon code option is available beyond coupon codes redeemed and zip codes? Will you share the percentage of positives, and would you inform the positives by coupon code? So to recap from the webinar, when we discussed this coupon code program, this option references an organization distributing coupon codes provided by OraSure. Those coupon codes can be redeemed on our website by your client, and OraSure ships a kit directly to your client on your behalf. Pam?
Yeah, our report would provide the specific code redeemed, the date of redemption, the zip code where the redemption occurred, and then tracking information on that kit where it was sent. At the beginning of the program, we send you a complete list of all of your coupon codes, and you really control how those codes are distributed. So one way programs can really understand more about the population they're testing is to really manage that code distribution and gather some demographic information on the front end before supplying that code to the client. And then of course you can take that demographic information that you've collected and cross-reference that with your HIV surveillance data after, a month or two down the road. The
next question says, when discussing home testing, it's always mentioned that tests are being used with MSM population, or men who have sex with men population. Are these tests not being distributed among heterosexual communities as well? How is the response from this community?
Yeah, it's a very good question. Initially, we believe that the use of in-home tests targeted the MSM population. A couple of reasons. Advertising on dating sites and programs felt like they needed to identify positive patients and really targeted those they felt were at highest risk in order to be able to validate or justify their program to find a high positivity rate. We know that everyone who feels like they're at risk for HIV deserves to have an HIV test. We believe that strongly. And we also know that there are big programs, in-home testing programs now, that have opened up their doors to test anyone who would like an HIV test during this time of COVID, when all populations have become hard to reach.
Thanks. Another question we received was, how are the clients who test positive being linked to care with so many agency closures?
Yes, yeah. And so one of the things we talk about to anyone who starts an in-home testing program is to have your referral plan in place before you start. And so really, we will rely on you, the community experts, to know where in my community today could I send someone who has a positive HIV test. And so that level or detail of information would change based on city and demographic and county level resources. So we rely on you to provide that information.
Are there protocols for informing individuals we interact with on social dating apps what information is reported to the Department of Health?
Yeah, that would really be more of a question for the HIV prevention policy program in your state. And if you need help contacting the correct person at your state Department of Health for that answer, we'd be more than happy to put you in contact with that person.
For reporting purposes, how are reactives documented?
Yeah, so when distributing test kits, states should include information on, if you test positive, please call this number. We know that 40% of patients from other tests that programs that are running do report back when they test positive. And then finally, to be able to cross-reference that HIV surveillance data down the line is very beneficial.
So we have another question around the coupon code option. And the question is the organization purchasing the test kits ahead of time and then distributing out the codes? It then goes on to say, I am asking to confirm the coupon code would provide a test with no cost to the client.
Yes, that's correct. The organization would set up an account with OraSure. You pre-purchase those coupon codes, and when those codes are redeemed, there is no cost to the client.
If an organization buys kits and wants to mail them to a customer themselves, how should they go about doing that?
You can mail the OraQuick In-Home Test Kit through the Postal Service. And so you can use their mailers and affix labels and just send it through the mail.
Thank you, Pam, for walking us through each of those questions. If there are questions that we did not cover today, or if you want to discuss some of these topics further, please visit www.orasure.com/relief. We look forward to having you join us for upcoming webinars, and we thank you for the impactful work you continue to do every day. Our team at OraSure is here to support you in any way that we can. Thank you for watching.
Thanks, everybody. Stay safe, stay healthy.